right, let's get into it. Today we're looking at a huge shift in how we approach a really challenging adult brain tumor, the craniopharyngioma. We're talking about a move away from just aggressive surgery to a new world of molecular precision.
So while these tumors are technically benign, their location, wow, it can be absolutely devastating, especially to the delicate endocrine systems that we as endocrinologists work so hard to manage. For years, the big question has been, how do we treat this thing without completely wrecking the patient's quality of life? Is there a better way?
So here's how we're going to break it down. We'll start with the clinical problem itself, look at why our old ways of managing it were so tough, then uncover the molecular key that changed everything. We'll look at the powerful evidence for a new targeted therapy, and finally, put it all together into a new treatment paradigm.
Okay, first up, let's set the stage. Why is this relatively rare tumor such a massive headache for both neurosurgeons and endocrinologists?
So craniopharyngiomas are not common, right? They're just a small fraction of all the tumors inside the skull. But we all know that label benign can be incredibly misleading. Because of their location, smack dab at the base of the brain, often tangled up with the pituitary and hypothalamus, they can be clinically catastrophic. And in adults, we're really dealing with two distinct subtypes.
Those two subtypes are the adamantinomatous, or ACP, and the papillary, or PCP. Now, ACP is more common overall, but our focus today, it's all on the papillary subtype. And here's why. This is where we found the key. The PCP subtype, which is about 1 in 5 adult cases, very often has a specific, targetable mutation, and that little fact changes the entire game.
Okay, so that leads us right into the central conflict of this whole story, the immense difficulty of treating these tumors the old-fashioned way, with a scalpel.
For the longest time, the goal was simple, right? Get the whole tumor out. A gross total resection gave patients the best shot at a cure. But that little phrase, when feasible, well, that phrase hides a world of pain and risk.
And here it is. This is the heart of the problem. This quote really says it all. These tumors are often stuck right to the hypothalamus. Trying to peel them off completely often means damaging that critical structure, which, as we know, leads to a lifetime of catastrophic problems. Panhypopituitarism, DI, unbelievable weight gain, cognitive issues. It's a mess. This chart just lays out the impossible choice surgeons have faced for decades. You can go in aggressively for a gross total resection and risk all that hypothalamic damage, or you can be more conservative, do a subtotal resection, and then face a coin flip chance, a 50% chance that the tumor comes back within 10 years. I mean, talk about being between a rock and a hard place.
But then, a discovery in the lab completely changed the equation, offering a potential way out of this surgical nightmare.
By looking at the tumor's genetics, researchers found a single, specific mutation that was basically acting as the engine for most of these papillary craniopharyngiomas. This wasn't just an interesting scientific finding. This was something you could actually target.
And just how common is this genetic driver? We're talking up to 95% of papillary cases. 95%! That is an incredibly high number, which makes it a nearly perfect bullseye for a targeted therapy. And that bullseye is the BRAF V600E mutation. Now, that name might sound familiar because it's a well-known bad actor in other cancers, like melanoma. And here's the best part. We already had FDA-approved drugs on the shelf that were designed to do one thing: block this exact mutation. Suddenly, all the pieces were on the board. So the theory was great, but the big question is, what actually happened when they tried this in patients? Let's take a look at the evidence, because it is pretty incredible. The results were, frankly, stunning. In a key group of patients with these tumors, treatment with targeted BRAF inhibitors led to an average tumor shrinkage of nearly 90%. Let that sink in for a second, a 90% reduction in volume. But you know, numbers don't always tell the full story. These next few MRI scans really show you, in vivid detail, just how fast and how powerfully this treatment works. Okay, so here's the before picture, the baseline scan. You can see this large, complex tumor wrapped around all those critical structures. This is a surgeon's nightmare.
Now check this out. This is after just 6 weeks of targeted therapy. The change is unbelievable. The solid parts of the tumor have just melted away.
And by 12 weeks, the response is even more dramatic. The tumor is just a fraction of its original size. I mean, this isn't just stopping the tumor from growing. This is a massive debulking, and it all happened without a single incision.
So, when you see powerful evidence like that, it naturally points to a brand new way of thinking, a totally new paradigm for how we manage these patients.
The new idea is to completely flip the script. Instead of leading with high-risk surgery, we use this targeted therapy beforehand as neoadjuvant therapy to shrink the tumor, pull it away from the hypothalamus, and make the eventual surgery dramatically safer.
So the new playbook for a suspected papillary craniopharyngioma looks something like this. 1. Get a biopsy to confirm what you're dealing with. 2. Test it for the BRAF V600E mutation. 3. If it's positive, you start the neoadjuvant targeted therapy. And 4. Only then, after the tumor has been tamed, does the patient go for a much more limited, function-sparing operation.
And this new approach directly solves the big problems we started with. It gives us a real option for those tumors that were once called unresectable. It gives clinicians the evidence they need to feel confident in a less aggressive initial surgery. But most importantly, it shifts the entire goal of treatment away from just radical resection and towards preserving that precious hypothalamus.
Which brings us to this final, really provocative question. When you see the evidence, the clear molecular target, the jaw-dropping responses on imaging, and the incredible potential to preserve function, are we actually watching the birth of a new standard of care for this disease? It's a question that every one of us in this field is going to have to grapple with.